you so much for joining us for NAMI Maryland's 39th Annual Conference. My name is Alexis Brown, and I am a volunteer with NAMI Maryland. I will be moderating for this session today. This workshop session is CIT Panel 911, What is the Nature of Your Emergency? Presented by Shawn Dundon from Harford County Office on Mental Health and Lucy Bill from Sheppard, Pratt-Hagerstown. You can read more about our amazing presenters, including their full bios in the digital conference program on the official conference website. This workshop will examine the public safety response to a behavioral health crisis. We will talk about the process from 911, including police, CIT officers, mobile crisis teams, and more. If this is not the workshop you meant to attend, please click the back button on your browser or click on the conference drop down on the left-hand side of your screen and select Sessions from the menu to return to the full list of workshops we have available. We will be addressing questions at the end of this presentation. If you have any questions as the presentation continues, please post them to the social wall on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we will ask our presenters after their presentation has concluded. If you have any comments, concerns, or technical issues, please post them to our social wall and our technical assistant will address them accordingly. When posting on the social wall, please be aware that there is a 20 to 30-second delay between the presentation and the stream on Conference Tracker. When this workshop session closes, you will be prompted to fill out a brief survey. If you would like to receive CEUs for this workshop, you must complete this survey in order to qualify. I'd now like to welcome our presenters for today's workshop, Shawn Dundon and Lucy Bill. Thank you so much for joining us.
Thank you, Alexis, for getting us going this afternoon. Really pleased to be here in this virtual environment. Much rather that we could see everyone in person, but this is pretty cool as well. We mentioned yesterday, it really wasn't that long ago we couldn't have even done this at all. So this is pretty neat that we can still continue to move forward in the digital realm, at least for now. But we're looking forward to seeing more and more people face-to-face again. So yeah, my name is Shawn. I'm from Harford County, Maryland, Office on Mental Health. I'm assigned primarily to the Harford County Sheriff's Office, and I'm the Crisis Intervention Coordinator for Harford County, which entails a bunch of stuff, and we'll mention a few things that Lucy and I do as we move forward. But say hi to Lucy.
Hey everybody, good afternoon. I work out in Washington County with the Washington County Sheriff's Office and the Hagerstown Police Department. We're also partnered with our first responders, our EMS providers out there. I coordinate mobile crisis services, and we're pretty closely partnered with law enforcement in our county. So that's one model that we'll talk about today, but it's great to be here and thanks everyone for being here.
All right, cool. So we've scribbled down a few notes here and there, our super high-tech outline, but we wanted to really use this time to talk about perhaps an area that we don't really focus on a whole lot is in the midst of a crisis, be it a behavioral health emergency or some other kind of mental health or substance use concern. What exactly happens when it gets to this point of needing to call 911, needing to call for help? What does that look like? What does it sound like? Can we investigate that and sort of discuss it for a few minutes? And Lucy and I will be sort of adding different layers as we move forward during the session in terms of what to look for and what different pieces of the public safety network participate in a crisis response. So really this session is to honor our true first responders, which are our 911 call takers, 911 dispatchers, all of our public safety communicators throughout the state. They're really the heroes. They're the ones that receive these calls from the community, and many times they're actually starting the crisis intervention process for us. Because when you're on the phone with them, those first few moments, those first few minutes are critical in terms of helping them develop that response. And we'll talk about that as we go here. But So for anyone that's called 911 for any kind of reason, you know right away, it's not a normal conversation. It's not like, you know, I call Lucy and say, hey, you know, what'd you think of that meeting? You want to talk about, you know, this element. It's not like a conversation we would have on a regular basis. Be it sort of looking at it from their perspective, 911 call takers have a system that sort of guides them through a series of questions based on our answers. One of the biggest things that I think people might feel some frustration with is their strictness. They have to really adhere closely to the protocol in order to develop the call that they're taking. They actually call it populating. So populating means as the information's coming in, they're punching keys. That population is helping develop that call and tying in the proper responders, whether it's police, fire, EMS, even hazmat, things of that nature. So it can be a little frustrating. I was telling Lucy actually an experience of calling 911 where it wasn't even a person, it was an automated system, and struggling to listen to the prompts, and I couldn't remember what number 2 was, and you get so frustrated you end up hanging up. But then the system doesn't let you hang up, it calls you back. And again, it's not a person calling you back, it's a computer. So that can be really frustrating. So a couple tips that we presented yesterday was, when you're about to call 911, first take a deep breath if you can, to help focus yourself, help center yourself to get through this questioning process. Because we want to be a good witness. We want to be a good reporter when we're calling 911 to report our issue. So we want to try to go slow and steady. They're going to ask your name, your location, a couple other things. Probably ask your phone number almost immediately. They'll say something like, in case we get cut off or in case we get disconnected, how can I reach you back? And again, this day and age, gosh, I would say at least 90% of us, Lucy, probably are on cell phones.
Right.
Most of the time. So having that cell phone number is critical. And even though they don't tell us this, a lot of their mapping technology would show them generally where we're calling from. So they might not know the house we're in, but they probably can find us in a neighborhood at least.
Yeah.
So all that technology is everything needed to help them pinpoint where we are, exactly what kind of help we need. So let's take a deep breath. We want to try to be slow and steady, give them that information, and as best we can, try to stay cool and calm. I'd much rather, go ahead.
Sorry, I was going to say, knowing that the main goal of the call taker initially is going to be assessing the level of risk and safety.
Exactly.
Then they can get to some more of the information of the details of the issue you're having and what kind of outcome you hope to see.
Right, right. And that's true for us as well. When we're talking to someone on a hotline, when we're talking to somebody either on the phone about mobile crisis or we're in person with mobile crisis, safety is number one. Nothing else really is important until there's some sense of safety for us as a caller, for our person, our loved one who we're calling about. They're going to keep harping on that. Are we safe? Are we able to talk freely? I mean, that can be a little frustrating when we're trying to get through our message. And as best we can to be accurate about the information, again, they're really relying on us to give them those details that's going to really help them. I mentioned something yesterday when Steve was on about, again, I don't have my radio handy, but if I had my Harford County Police radio on, I can almost guarantee that there's a mental health call happening like right now. And there's a pretty good chance I might even know who's involved. So if I could just sit home with a radio all day, and navigate calls and direct resources, that would be great. But when we're out and about, again, we want to be good reporters and good witnesses.
Yeah, I think when we do a lot of our different trainings in like police academies and things like that, we try to help frame the idea that, maybe upwards of 80% of patrol calls have some sort of behavioral health element to them, be it mental health, substance use. So call 911 call takers are definitely used to navigating these kind of situations and helping us determine best next steps. And I think also another point of importance of giving your accurate phone number of how to reach you back is also, like Shawn was saying, it can be frustrating where you want to share the details about the person you're calling for or the situation. But once that safety has been established and we know which units and what type of response is required, then maybe the responding officer or responding mental health unit can also contact you and get a little more information that's more specific as well. That would probably come at a later point in the response.
Yeah, and there's a couple different mechanisms for 911 response as well. I mentioned about the automated system where you would really have to navigate multiple layers of that system to actually get to a person. In my environment, and Lucy, I believe in your environment, you're going to have a live call taker on the phone with you who is going to be working their system. Ours is called ProQA, which is what guides them through the system. I'm not sure if that's the standard for the state, but that's the most one I've heard. So you have a real person on the phone who, like Lucy said, once they get to that level where they have a pretty solid call developed in the computer, then they do have a little more freedom to sort of let you tell a little bit more, or they'll ask you questions that are a little more off of their protocol. And in some places, there's two people perhaps. So maybe I'm the call taker and maybe Lucy's the dispatcher. So I'm taking that call, I'm speaking with that individual, I'm putting information into the system, and let's say I've already flagged it as a mental health call. So Lucy on the dispatch side says, oh, look, it's coming through as a mental health call. Maybe it's a behavioral disturbance, something along those lines. And look, the caller actually requested a CIT officer, actually requested, I'm trying to get the mobile crisis team out. So that automatically gives Lucy the ability to dispatch to the units and say, this is a mental health crisis. Caller is actually requesting CIT and mobile crisis. So they all hear that. All the units that are on hear it together. And my experience has been, we'll actually have CIT trained officers jump on that call and say, hey, I'll go there too. Or if I'm out and about, sometimes I can contribute as well.
I think helpful to keep in mind too, that most jurisdictions in Maryland using that ProQA system have some requirements they can't work around. So sometimes that might determine, even if you're wanting, completely understandably, the fewest number of units responding, hoping that law enforcement won't have to respond potentially, no lights or sirens, things like that. Those are all reasonable requests, but just to keep in mind that sometimes based off of the way questions are answered and how the questions sort of filter down, that will really limit dispatchers with having some freedom to make choices about which units to dispatch and when, but sometimes they just don't have flexibility legally or ethically because of their system. So just to keep that in mind, they'll try to get the best, most appropriate units to your call, including, like Shawn said, CIT trained officers or a mobile crisis supplement, but sometimes you might not be able to completely request exactly what you're hoping to see.
Okay, great. So maybe I'll talk about what exactly CIT is for a minute. Yeah. And Lucy, you can follow, I guess, with more about mobile crisis resources. So in the state of Maryland, all jurisdictions all have access to CIT. CIT stands for Crisis Intervention Team. Sometimes we just say Crisis Intervention Resources, but all jurisdictions have had this since 2013. The State Behavioral Health Administration has basically base funding for the whole state to either help establish CIT training for public safety, law enforcement, expand or enhance existing programs that already do that. So over the course of these years, all these different jurisdictions have all been moving in this same direction, sort of aligning more and more each year to where we soon hope to have a really standardized program throughout the state. We have resources in every jurisdiction except for, I guess on our list, Lucy, is Cumberland and Oakland are two places we've kicked around a few times that we'd like to see CIT established in Cumberland City and also in Oakland. So we might go on a field trip or something out there to scope it out.
Come out my way, come out west.
Yeah, let's go. Let's go. Yeah. But we're excited about that, and we're actually proud to be able to say about our coverage. I mean, one of the standard requirements for CIT and crisis intervention training is we really want to have a minimum of 25% of any given jurisdiction or agency trained by us in our 40-hour CIT training. Most of us offer that course 1 or 2 times a year. It depends on how large our county or our jurisdiction is. So that's really the standard that we're using with all of our partners. It takes dozens of partners to put on any of these kinds of trainings. Most of the history of CIT goes back to Memphis in 1988 with NAMI, and Memphis Police really conceived CIT back then, as well as mobile crisis started in the country as well around the mid 80s. So Lucy, if you can share a little bit about what some of the mobile crisis resources look like and how that's part of our response.
Yeah, and I think every jurisdiction has different partnerships between their CIT trained officers and how they utilize them for response, and how they utilize mobile crisis in their county. Sometimes it's just a matter of how many units are available and when they're available. But generally the idea is to have either licensed clinicians or mental health professionals, or even in a lot of areas, peer recovery specialists or peer mental health specialists who can respond in the moment of crisis out in person to any situation. They, depending on the level of safety and on the scene, and also the intensity of the situation, it might be a co-response with a CIT trained officer. It might be a specific officer that's hired as part of the team, or it might be just a regular patrol officer responding that the mobile crisis unit can coordinate with. But the main goal being to bring a specific resource out directly to the moment of crisis in the person's environment that they're experiencing the crisis, so that there can be de-escalation, a mental health response, and then also what we've talked about, the potential evaluation process, that can be more accurately and effectively utilized. And a lot of our goals for all the trainings is reduction of unnecessary hospital transports for people dealing with a mental health crisis, and also reduction of unnecessary engagement with the 911 system, or with even potentially arrest as an extreme example.
Oh yeah, absolutely. Even though our CIT trainings, our 40-hour courses are extremely demanding and tiring and exhausting, we look forward to them because it's such a unique opportunity to have our public safety partners with us for an entire week. We have all kinds of different material in the curriculum, and everything from role plays to a lot of hands-on exercises and things that they probably never have had before. They may have had some very basic mental health stuff somewhere along the line, but this is a really special time to have their almost undivided attention. So when we're in the training, we really want to grab them and say, what are you going to do? Get right in their face and say, what are you going to do when you respond to somebody in crisis? I mean, do you know what the differences are between maybe psychosis or maybe alcohol impairment or some sort of drug influence. I mean, do you know how to look for the signs, of those things? And what are you going to do if someone is presenting as suicidal? Do you know what your resources are, like Lucy talked about? Do you know how to interact with your mobile crisis or hotline? What kind of relationship do you have with your local hospital emergency room? It's a guarantee they're going to end up in the emergency room at some point. Despite all of our best intentions and hard work, people still go to the emergency room with the police for evaluation. We talked about emergency petitions a little bit yesterday. The official term is petition for emergency evaluation, where law enforcement, public safety, doctors, psychologists, specifically licensed mental health professionals can order a person for an emergency evaluation at a local hospital. So as long as it's the proper person and the proper circumstances, that the criteria is there for that petition, it's going to happen. And it's going to happen with a pretty good frequency. I don't have numbers for other jurisdictions, but just to give you an example, it's not unusual for Harford County Sheriff's Office to complete 60, 70 EPs a month. There's been a few times where it's gone really high as well, but we want to make sure that those are not just legitimate EPs. We want to make sure that they're done properly and that they really do have a relationship with the emergency room, that they're just not taking a person there and dropping them off, but they're really going, they're making contact with the staff, they're doing like more of a warm handoff, even though it's a petition. It's still an important opportunity to make that connection.
Right, because that engagement and advocacy is important for those times when unfortunately someone does need to utilize a hospital level of care. We want the person to actually be able to stay when needed, versus it getting left on a technicality or something like that. Yeah, it's important.
Yeah, absolutely. I mean, in my mind, I guess my personal rule is, I'm not going to write an EP on a person that I don't feel extremely strong that they can actually be admitted. Because most of the folks that do end up in the emergency room actually don't get admitted. It's somewhere in the vicinity of maybe 40%, something like that. So maybe around 60% of the time, people do get that evaluation, but they don't stay. They're not admitted, to a treatment environment. So that generates a lot of frustration as well.
Yeah, that's
for
why
officers and for the public.
Right. That's why it's, I would say, important as if you're a person who identifies as an advocate for a loved one or for clients in the community. So important to familiarize yourself best you can with what sort of resources you have so that you can ask to coordinate with them, so that you're getting that nuanced response, and only so there is maybe a CIT officer on scene or a mobile crisis on scene to do exactly what Shawn was saying, of having a nuanced understanding of when is it necessary and appropriate to get someone to the hospital or not.
That's why mobile crisis is so important, and so important to be connected to a live hotline person as well. There's all kinds of different layers of hotline, but to know what the local resources are is super important, and to really have a relationship with them. We always encourage our public safety to go visit the crisis team, talk to them on the phone, get to know them a little bit outside of a crisis, so that they have a better understanding of how to sort of navigate that when the time comes. And the time will come pretty fast. We tell the young officers in field training, it's like, I'm not kidding, you're going to have a mental health call your first shift. I guarantee you're probably not even going to make it to lunchtime without having some mental health related call. So you really have to know what to do. You really have got to know how to navigate that. And like Lucy said, it's really so important about de-escalation and diversion, to avoid all those things that we really don't want to get into. We don't want people to have to go to the hospital. We really don't. If that's what's necessary, we're on the same, on the other hand, we're not going to waste time. If someone clearly needs to go, we want that to happen as quickly and as smoothly and safely as possible. But in tons of other circumstances, we have the opportunity to use mobile crisis. We have the opportunity to use a walk-in center, for instance, instead of an expensive and very time-consuming emergency room, and definitely want to try to avoid any unnecessary arrests. Yesterday, when Steve was on, we talked about kind of the frustration of perhaps taking someone to that's arresting someone for a very minor offense. Let's say it's disorderly or trespass or something really minor, where it's almost like you take them to the facility to be processed, and you're driving away and you see them in your rear view mirror coming out already. And they probably come out with a court date or something, but they're not staying there. So you really haven't solved any problem. You may have intervened in that moment, but nothing else has been addressed. So, what is the root cause is one of the things that we mentioned yesterday. And here's an opportunity again, trying to make the best of maybe a difficult situation. How can public safety recognize and respond to crisis?
Yeah, and get only the necessary response involved and not have any unnecessary intervention, I think is a lot of the main goal of crisis intervention related in the 911 system.
Yeah.
No undue harm or intervention in these situations.
Exactly. Yeah, because any of us that have lived experience for ourselves or loved ones, we could probably tell some stories about our efforts or our attempts at navigating public safety during a crisis as well. More than one occasion, I've had to figure out crisis resources for a relative out of state. I've had to try to navigate mobile crisis teams in other states, being on the phone with police agencies in different locations. Trying to do things like that is really frustrating. And it's like, I'm supposed to be good at this.
Yeah.
We're coordinators for a reason. We're supposed to, have some, expertise here, but you feel totally lost and very frustrated. And, I've hung up on a few that I wouldn't treat me this way. But yeah, that's what we're really drilling down to is when it comes time to call 911, we want to do the best we can. And like Lucy said, minimum response is always great because those hot calls that come through, you're going to get a massive response. It has to be that way. If there's a mention of a weapon, if anyone's been hurt, or it's an active scene involving violence or things of that nature, you're going to get a huge response. So the best we can to help our 911 communicators direct that call, it is going to help keep that response appropriate and hopefully to a minimum. But yeah, we're always happy to sort of hear people that are requesting CIT on the phone with 911 or asking for mobile crisis support. That makes us happy that either they've utilized the system before or they're familiar with it and can put that out on the air and say, yeah, this is a mental health call and they're asking for mobile crisis. So that helps the officers say, hey, maybe just like two of us go. We're going to be chill about it and we'll wait for mobile crisis to come and we'll let them take the lead. No one's in immediate danger. No one's been hurt. This is some sort of behavioral health emergency. Let's let them take the lead and go that way. So that's always encouraging.
Great. And I think the other piece too, and we talked about it a little bit, is hotlines. And it's difficult as the person calling. I totally recognize that, to determine and decide what level of response do I need. So if you are not in active danger, if the person you're calling about is This is sort of a really loose, vague description, I recognize, but generally speaking, if there's no danger to life or limb, no active risk and need for 911 response, you can start with, in Maryland, calling 211. That's our general go-to guidance, is to start with 211, to be able to talk through, this is what is happening. This is what if you are the person in crisis, or if someone you know is in crisis, you can explain the situation and they can help you navigate whether there is mobile crisis in your area. Could they respond maybe without police based off of the level of risk, if it's low enough? Or they can help get you directly connected to 911 if they think it's to that level of need.
Yeah, most of the mobile crisis teams in the state are separate, sort of partner with law enforcement and public safety. So in general, like in Harford County, our Office of Mental Health, we operate the 24-hour hotline, we operate the 24-hour mobile crisis team, and then the hospital has the walk-in center in the same building, but there's no public access to the hotline or mobile crisis, but yet people can walk in up front if they want to. And I think most mobile crisis teams are perfectly happy not having law enforcement there if not needed. But just to give you the flip side, the program in Baltimore County is called a co-responder model, where they actually have, it would be myself or Lucy actually in an unmarked police car with a fully trained certified CIT officer, and that's all they do, is respond to behavioral health concerns. They don't respond to normal everyday calls for service. They're only out there to address mental health and behavioral health concerns. So that there's a couple counties that do it that way, but most of us are in a partnership situation with a provider. And I guess we could talk about LEAD here, Lucy, as another layer of the crisis response.
Yeah, when we talk about diversion and trying to make sure the right resources and the right response is going to the right place, LEAD is another model, stands for Law Enforcement Assisted Diversion. It's a model out of Seattle, Washington, and it's collaborative between all community entities, including law enforcement, ACLU, and case management providers. And the main backbone of the services, the easiest way to describe it is a harm reduction model. So focusing on how we can address, like we talked about, underlying root causes for someone's chronic engagement with the 911 system. So if someone is chronically interfacing with police or EMS because of a mental health issue, we know that arresting that person for low-level offenses or just for being visible in the community, basically, is not going to address the root cause of why that's happening. So I coordinate both mobile crisis and the LEAD program because a lot of our clients in the community who are chronically engaged with law enforcement end up overlapping. So we try to invest a lot of intensive case management services for individuals who are LEAD participants to try and completely divert them from law enforcement interaction. That's our main goal. And unnecessary arrest, and sort of what is referred to as the revolving door of arrest, release. The person's situation is maybe unstable, so they're not able to make it to court. And so then there's just a failure to appear warrant, and that doesn't help anyone either. So we partner really closely with law enforcement for that programming to divest energy and time from law enforcement unnecessarily engaging with individuals in the community to intensive services that can actually address those issues. So it's relatively new. Washington County, or there's a pilot in Baltimore City, and Washington County is one of the first counties to have a full program, but a lot of other counties in our state are getting those services and are and like starting up different pilot programs, which is really exciting. And there's been a lot of push to prioritize that in Maryland, which I think we're all really proud of.
Oh yeah, absolutely. In Harford County, our lead provider is Bel Air Police Department. And I mean, it's been going great. I guess it's been a couple years, 2 or 3 years now, but it's been going really well. We definitely want to expand it to the whole county. But just as an example, they communicate very closely with not just the mobile crisis team, but the walk-in center as well, because they get a lot of referrals through the emergency rooms for people that have come there for various reasons, and they're not getting admitted to a facility, but yet they are in need of at least some more advanced care. So LEAD is an awesome way to connect them, get them into the system, and try to intercept them during their crisis, so they don't end up either back at the ER or don't end up in some situation with law enforcement or the courts. It's always surprising, not that I do this for fun, but occasions where I've had to go to court for different reasons, time and almost every single time I see and hear people that I've dealt with before, and or are presenting with some sort of behavioral or substance use issue as complicating their reason for being in court, be it a DUI or some other kind of charges. It happens all the time. And that's another area that we could talk about all day long, is mental health court and court diversion and all that. But LEAD is just an example of really connecting public defenders, local courts, circuit, district courts, in sort of like this process of public safety, the detention center, and all these different entities as well. And Lucy, I'm glad you mentioned peer recovery as well. That's something that we didn't really have here in Harford County until the last year or so. Part of our mobile crisis is we have 2 full-time peer recovery specialists, and they connect very closely with emergency rooms as well. Sometimes it's like post-overdose or some other presentation at the hospital, be it substance related. And most of the time it's not just substance, but there's some kind of co-occurring disorders going on. So again, that's a really important intercept point, is the hospital emergency rooms where people are seeking care, and they're probably not going to get admitted, but let's put a peer in that situation to really sit down with them in person and have that not just warm handoff, but like a hot handoff. And not miss that opportunity, because it's frustrating, right? Some of us have probably gone through emergency rooms or taken a loved one or a friend to an emergency room, and it makes you want to pull your hair out. Let's be honest. So we're looking for all these opportunities to intervene, intercept, divert, de-escalate, use all of our crisis intervention resources, get them in the system in a sort of a safe and quiet and calm way, which is always best.
And particularly for individuals that find themselves in a crisis level situation or chronically experiencing a crisis level of mental health symptoms or suicidal ideation, whatever it may be, traditional services don't necessarily fit or help or work for that person. So I think, on just as an additional point on top of everything you said, that's wonderful, Shawn, just to be able to have an alternative to a traditional sit-down therapy appointment or whatever it may be. As a specific example, I think that's one of the ways we're able to divert and address situations in a different way, because it is a non-traditional response, and that we can follow up with someone and make sure they are actually getting the support that they need in a way that just wouldn't happen without that connection to the 911 system. Right. I just don't think.
Right. I mean, if any of us, started right now, and I almost said look in the phone book, but I don't have a phone book anymore. But if we started right now, I'm seeing exactly 3 o'clock. If we start right now and try to secure an outpatient appointment with a regular, private therapist, how long do you think that's going to take? I mean,
Right.
do you think you'd be able to get an appointment within a week or 2 weeks or a month? And you can look at
Yeah.
it too. I mean, you chime in, Lucy, but you can look at it two different ways. One way is, gosh darn it, I need to see somebody right away. I can't wait 4 weeks. Or you can think to yourself, wow, that must mean there's a lot of people getting help. I guess I can wait a few weeks. I mean, do you experience that too? Do you hear that on your end of the counter?
Yeah, for sure. Yeah, I mean, then again, we could have a whole other panel about insurance and
Right.
transportation how do you get to the appointment? All these things. Yeah, I think I very much value being able to provide something that bridges people from needing assistance or intervention to the point where you can get into longer term outpatient services.
Mhm. Mhm.
Yeah.
And really, I mean, even being in this field for X number of years, it wasn't that long ago. Not only did we didn't have CIT, we didn't have mobile crisis before. Basically, mobile crisis grants started in Maryland in basically July of '98, and teams started appearing at the very end of '98, and like Harford County started in the beginning of '99. So really, it wasn't that long ago. Lots of these resources didn't exist. And even when I started in the field, it was much more, I'll say, old school, traditional psychiatry, where a person went to therapy, a person had a psychiatrist for meds. There were very few, there were some, but not a whole lot of day programs and alternate levels of care. A lot of the ones now, nowadays, there's just a wide variety, huge number of options compared to what it used to be. And it can be hard to navigate, where you actually fit in. Yeah.
Right. Agreed. I was looking at the questions coming through a little bit as well. We don't have to jump to questions, but I was just getting a little distracted. I apologize. Talking about longer term care, and that's sometimes difficult to fit into the conversation about crisis response.
Right.
But it comes up because like you've explained, Shawn, we're seeing individuals maybe more than once a year, more than once a month, with dealing with similar issues where traditional services aren't necessarily fitting for that person. And how do we navigate those situations?
And most of us in crisis intervention are really like gatekeepers. So we may see people come and go through the same gate several times, but we don't always know where they ended up, for instance, unless we see them sneaking back out of the system. And it's true. I mean, people do come and go out of what we call the system with some frequency, and we don't always catch them. We don't. But we're always trying to keep our eyes open. And the more people we can educate and enlighten and train to be on the lookout for people that do need help, we want to certainly make the most of it. A lot of us in our jurisdictions are doing community outreach and homeless outreach, things like this. I mean, I never really realized how much of that's going to be part of my job.
Right.
I kind of do it, to some level, but I didn't realize what a huge job it is, being sort of on the lookout and trying to intervene with people that are on the street in different kinds of ways. We're seeing a lot more people even living in vehicles and stuff like that too. So a lot of the folks, may in fact have, mental health or behavioral health or substance use concerns going on. So yeah, maybe we're going to meet that person at the park and ride. Maybe we're going to, go to Dunkin' and grab some coffee and donuts and go look for, someone that apparently is living, in the woods or whatever it is. But
that's huge. That's hugely important value that I think mobile crisis being really flexible and able to be creative is important because, I mean, even just 1 ounce of trauma-informed care will have you know that being able to build a relationship with someone and be a familiar face maybe 5-10 times, it's understandable that it will take that long before someone wants to engage based off of their mental health or trauma history. So I really I think all of us mobile crisis and CIT providers are proud of being able to navigate that with alongside someone and meet people where they're at, as to say, to coin a phrase.
Yeah. And I mean, not to sort of blow our own horn here, but we are proud of the CIT coordinators network throughout the state. And we feel like we're really at the front edge of what the state is trying to do. If any of the participants have seen the movement in the last few years, especially Governor Hogan has really made crisis intervention and crisis response a huge priority. And not just legislation, but funding and different things are coming into play that's sort of pushing us in that direction. And we're actually in the midst right now of trying to basically have a state level coordinator that would sort of be responsible for helping all of us in our jurisdictions all stay going in the same direction and just continue to do more to align and sort of make sure we're all on the same page as we move forward. Because most likely in some number of years, CIT itself, the training we provide for law enforcement, public safety, it's possible that training could actually become mandated at some point. And I don't know if that's ideal or not, but we want to stay at the front edge of that either way. We want to already be there if in fact that comes down to say, we think everyone should be trained. And that's why we're doing everything we can to fill gaps. That's why we include our police communicators and 911 and things like mental health first aid, PPR, coming to our CIT training as well, because we're all kind of contributing to this crisis response as best we can.
Yeah, you were speaking about the future also of the emergency response system as well, moving towards the implementation of the 988 system as well, just as something to look to for the future in our state and across the U.S. as well.
Oh yeah, I mean, trying not to mention anything going on in the news, but I think most of us probably cringe when we hear some things happening in the community. In our minds, we're kind of wondering, is it a behavioral health, substance use crisis or behavioral concern? And sometimes it is. And a lot of our training is also, we want to help the general public know that mental health in general, mental health concerns doesn't automatically mean that someone is, more dangerous or more of a threat than another person. That just doesn't play out in real life. The problem is when things pop up in the news or in the community, those headlines, sort of grab people's attention. And we know better, being practitioners, that's not statistically true. We're more likely to be, hurt in a car crash or, get mugged downtown or on a field trip or something than be harmed in any way by someone that is actually experiencing, a behavioral health concern. And that's one of the things we teach in CIT, among millions of other things. Yeah. So do we want to look at this question or anything else, Lucy, we need to mention?
Yeah, the question is, our school is having a large number of behavioral health of behavioral crises.
Right.
I think due to students being back in the classroom after at least 14 months. Can school contact CIT ahead of time to try to formulate a feasible response? Thank you for your question. Definite. I think quick answer is yes.
Yeah. A little more complicated, but yes.
Yeah.
I would honestly, I would first think about local mobile crisis resources. So yes, CIT in the sense of CIT trained officers. I don't know if you have school resource officers in this area or involved with this school. We try to make sure almost, if we can't get all of the school resource officers trained in CIT, they should be. So that is a resource. But I think finding out what your local mobile crisis resources are, and do they have a youth crisis component, and do they have any like family advocates or things like that that could help as well, because it might be a good idea to get them connected if they're not.
Right. If they, that's what I was going to say. If they don't already respond directly into your schools in your county, that's something you might want to explore. It's definitely an option for mobile crisis response. There's a lot of logistics involved, of course, with allowing new teams into the schools, but I think they're definitely a really mobile crisis would be a great resource, because you can consult with them about what you're dealing with. They can help you decide and navigate when and how to engage law enforcement, those things.
Yeah, just keeping in mind, Lucy touched on it for a moment about it sort of opens up a whole can of worms when outsiders are going to come into a school. And let's just suffice to say, school resource officers are swamped. So they may not even be involved in certain crises, but mobile crisis coming into a school, we always have to have parental permission. We always want to make sure that the school is already using their counselor and administration before mobile crisis would come, because you wouldn't want, your child to come home from school one day and say, oh, Dad, mobile crisis came today because they saw me reading Guns and Ammo magazine. You don't want that. You want the parent or guardian or whomever to be involved with it if it's affected the school to that level, where you have to have an outside agency come in. So just to keep that in mind. But maybe take some steps and figure out how the local mobile crisis can intervene. We are fortunate to have just added a whole youth sort of division to mobile crisis, which is awesome. So we can send them to interact with the school counselors. And we also do have a family advocate now as well. And she's able to really look at these cases, look at these responses, go visit the home, a whole bunch of cool stuff.
Yeah. And I think too, be it with this specific question or any situation, I think a lot of times with mobile crisis, we advise that even if you do have to utilize 911 response or a school resource officer, whatever it may be, you can also always still coordinate with an additional resource such as mobile crisis to help advocate for a more nuanced approach as well, as like a supplement to what is happening as well.
Absolutely. And something as our CIT and as our mobile crisis teams mature over time, we have more room and more availability to do follow-ups and stuff too. Because if you're only responding to crisis, Lucy and I, we're going to be super tired. But if we can also advocate and intervene sort of on the other side of things, that's pretty awesome too. There's a lot of value in meeting with people outside of that crisis response. And that's what the newer mobile crisis teams are doing more of. It's just really great to do that. I wish I had more time.
I know, right? I think you might find in most jurisdictions in Maryland that mobile crisis is at the table at a lot of community meetings, a lot of specific case consultation meetings for individuals at risk in the community.
Mhm.
So you might find that just communicating about a rising concern or a ongoing crisis that you're navigating for someone, if you communicate with mobile crisis or someone similar in your community outside of an active crisis, there's probably a lot of advocacy and coordination they can do as well. Yeah.
And thanks for the question, because that is a huge sort of stressful situation for the kids and the teachers and the parents.
Mhm.
You know, if there's 1,000 kids in a school, I mean, there's like tons of staff that are required to make that go.
Mhm.
So yeah, this impact it still shocks me to think about this as a worldwide impact, and however it's affecting me in my little piece of the world, thinking that way, like, wow, this is affecting the entire earth.
Mhm.
How can I contribute to that? How can Lucy contribute to that as we're able to intervene and meet people in all kinds of ways? So I think we just have a few more minutes left, or seconds. I'm not sure.
Any other questions? Yeah.
Yeah, questions before we go. Our contact information is available through the conference, so feel free to shoot some emails to us as well, and we will respond to you over there as well.
Yeah, I do see one more question that came through.
Yeah.
How much have the mobile units and related staff grown over the last few years?
Wow, a lot. Like I mentioned, the first mobile crisis grants came from the Behavioral Health Administration in Maryland, came out in July of 1998. And like I said, teams started to form at the end of that. Some of the first ones were Baltimore County, Baltimore City, Harford County, and kind of around the same time was, like, I think it was Arundel. There's sort of about 4 or 5 of us kind of started around the same time. And then over the years, it has expanded pretty much statewide. And so the mobile crisis track, that started in the mid 80s, mostly on the West Coast. CIT, I mentioned, began in Memphis in like 1998 or 1988 with NAMI. So that track has gone a little bit differently, but sort of parallel paths. And now the only 2 places on our radar right now, we said in the beginning, was we really want to get something on the ground in Cumberland and get something on the ground in Oakland.
Mm-hmm. And if it's a really specific reference, like in Washington County, for example, it's only been the past 6 years, 7 years maybe, that there was any mobile crisis presence at all. And then only in the past 2-3 years have we had a full team in our county. So just as an example of more funding opportunities, it's been more prioritized at the state and federal level. So I think that's where we've seen a lot of growth. And also, just as Shawn, as you described, I like as the teams mature, yeah, we've had, just it takes time to engage all the systems you need at the table to have a robust mobile crisis response, to even be invited out onto 911 calls. That takes time.
Yeah.
And then once that is established, I think we've seen in the past years more expansion of actual staff and hours and things like that.
Right. Yeah, even though Harford County has had mobile crisis for a good while, we've only had 24-hour coverage for like 2 years. We just never, funding was part of it, but just the community as well. It got to that point of it's only been like a few years of doing that. But I saw Kate pop in here somewhere before, but I just wanted to specifically thank Kate Fahrenholt. Kate has been a huge voice and a huge advocate for mobile crisis intervention, CIT specifically from the very beginning. And those of us that have known her for a good while know that she has been a huge advocate. And we just really want to thank NAMI in general, because as you can tell, we're super casual and it's just kind of how we roll. And if you run into other CIT coordinators, most of us are kind of chill, like we are, because we're just really passionate about what we do. And we never could have done any of this without the Behavioral Health Administration support and funding. Never would have been able to do any of this without NAMI being our best partner from the get-go, just in terms of support, funding, advocacy, everything like that. So we're just real thankful that we have this opportunity, and we're just really glad to be here.
And we thank you both so much for your presentation. This was great information, and you stayed in there for 2 days, so people got it yesterday, and you came back today, because definitely, you said, Shawn, about advocacy and reaching out. I think that is a huge piece of it also, is kind of, getting the word out and letting people know, who you're about and what's going on. So thank you again so much for joining.
You're welcome.
Everyone.
Thank you. Thanks, Lucy. Pleasure working with you.
Great. So when this workshop session closes, you'll be prompted to fill out a brief survey. If you would like to receive CEUs for this workshop, you must complete this survey in order to qualify. The next workshop session will begin at 3:30. So be sure to check out NAMI Land and other amazing virtual resources in our virtual exhibitor hall. And don't forget to participate in our resource scavenger hunt. If you find all the resources listed and submit your answers by the end of the conference, you'll be entered in a raffle to win a DSW messenger bag. And again, Shawn and Lucy, thank you so much for coming back today and giving us an amazing presentation.
You did a great job. Thank you so much, Alexis.
Thank you all. Take care.
All right. Take care.
Bye-bye.